Moving forward into the kidney injuries or the renal system. So acute kidney injury, known as AKI, is a sudden decrease in kidney filtration, which resultantly increases the level of toxins in the blood because, again, the kidneys are a primary filtration source for the blood. It's often reversible if diagnosed and treated early with the appropriate medications or procedures. The patient may experience edema, acid buildup, high levels of waste products in the blood. And so we're going to talk about these three things. The edema is because we now have some kind of systemic vascular resistance because, again, the kidneys are a primary filtration device. There's a lot of blood flow that needs to go through there. If they're unable to make their way through the kidney, we start backing up pressure, which then pushes fluid out of the vasculature into the interstitial space, and then we get that pedal edema, so to speak, right? And so this is very similar to something that somebody may experience if they're in right-sided heart failure. The acid buildup is a no-brainer. We're talking about metabolic acidosis because of the byproducts of the metabolism and other things like that. These things will accumulate in the bloodstream and then the patient will become acidotic. The high levels of waste products will continue to build up, and then we can end up with something called hepatic encephalopathy, which is an altered mentation state simply due to lactate levels or the lactic acid levels in the blood causing the mentation shift. If these patients go left untreated for a significant amount of time, they can ultimately end up in heart failure. They're obviously going to have some hypertension, and they're obviously going to be metabolically acidotic. And when we went through cardiac, I had mentioned very specifically in CHF, the kidneys play a function in the exacerbation of CHF. And when the kidneys are not able to filter at the correct volume or correct rate, the vascular resistance goes up. The heart now is unable to actually pump against it. It's weakened either through acute or chronic causes. And then the kidneys now sense another decrease in flow, and the kidneys will actually tell the body to hold more fluid. So you can see that that's a vicious cycle that can actually end up harming the patient as a means of itself trying to self-preserve. So just try to pay attention to the way the body systems work, and this is a good cue into how CHF and kidneys play along with each other. Chronic kidney disease is progressive, it's irreversible by definition. Inadequate kidney function is the obvious cause, and then it can have the underlying causes of many different systemic disease processes. It can also be as a result of a congenital or a birth defect or disorder. The chronic renal failure is a condition of nephrons in the kidney becoming damaged. And remember, those nephrons are kind of filter shaped, right? And that's really what we're looking at, doing the filtration. So they're funnel shaped. It's allowing the salt and the water molecules to pass through. When those become scarred, they tend to have less flow or no flow. The scarring continues to build up, and as waste products and fluid back up, this causes further damage until we get into a systemic complication where the kidney is so overloaded we get into the acute renal failure, which then, as described, becomes a chronic problem. These patients almost always go into an emergency dialysis and then will become a lifelong dialysis member. Some of the signs and symptoms from these renal problems are altered LOC. If you guys remember, I love the acronym AEIOU TIPS, right? And the U is for uremia, which is the urinary problems. And so if we're not filtering out the toxins or the byproducts of metabolism, this is where we get those toxins or the acidosis in the bloodstream causing kind of leave from homeostasis, and the resulting symptom is the altered mentation. Seizures, coma, lethargy, nausea, headaches, cramps, and then signs of anemia, which is low iron in the blood. So you guys can see that that's like a low red blood cell count. There's also another thing called uremic frost. There are many other signs and symptoms of this where we have pale, cool, and moist skin because the patient is actually in shock because of their inability to actually perfuse. Also, bringing in the conditions of edema, some muscle twitching because the electrolytes are now out of balance, hypotension, tachycardia, pericarditis, and pulmonary edema, again, because it's very specifically related to that CHF. End-stage renal disease, a patient with this has lost most of their ability for their kidneys to function. A normal adult can survive with a decreased kidney function of just one kidney, but 1.5, that's obviously far too significant to have lost. And so the toxic waste build up in the bloodstream rather quickly. It's very fatal unless it's treated by dialysis or they get some kind of kidney transplant. Unfortunately for most people, due to the way that transplants have to be performed, most people end up on some kind of dialysis. Which they have a fistula placed in a large vessel in the arm, which gives an access port for a filtration device external to the body to filter the byproducts and waste out of the bloodstream and then put it back in. So anybody that understands some of that stuff knows that we definitely have some issues with people who are on dialysis. We cannot take a blood pressure over the top of a fistula for the simple fact that we may cause damage to it, and you can't compress that significantly, and we certainly don't want to ever try to access that with a normal catheter. Some of the signs and symptoms of end-stage renal disease are going to be confusion, right? That's an altered mentation because they're toxic, they have acidosis, the bloodstream is completely non-conducive to homeostasis. And then we have shortness of breath because we may have some fluid backing up into the lungs, and so now we're not quite with wet lung sounds yet, but we're starting to get those first stages of that where the patient is now perhaps just getting the simple act of gas exchange across the alveolar pockets is not working very well. They'll have peripheral edema because, again, that systemic vascular resistance is backing fluid up into the interstitial space. They can get bruising, chest pain, and bone pain. As these toxins continue to accumulate, pruritus, nausea, and vomiting, muscle twitching and tremors, as well as hallucinations can result. They'll become pale, cool, and moist, which is, again, a sign of shock, obviously. And then we have the edema, which is the fluid backing up, and then the uremic frost. In the later stages, these patients will develop such a metabolic acidotic state that they'll go into seizures and possibly into a coma. Working our way into the female reproductive organs, gynecologic problems are really actually a pretty common cause of abdominal pain. So what we want to make sure that we talk about is that anytime you have a female patient with a lower abdominal pain and tenderness, this may be related to the reproductive organs. And so there's a couple of key questions that we want to make sure that we get from the patient, and we can't be shy about it, right? And so some of these things may just be parts of the consideration of the reproductive cycle, and then some of them might have to do with pregnancy. PID, or pelvic inflammatory disease, is an infection of the fallopian tubes and the surrounding tissues. There's intense pain and tenderness in the lower abdomen, usually accompanied by a high fever. Ectopic pregnancies generally do not have a fever associated with them. The bigger problem with an ectopic pregnancy is that this patient now has an internal hemorrhage, and this happens when a fertilized egg implants outside of the uterus. More often than not, that fertilized egg is going to implant into some part of the fallopian tube, and if you guys are thinking about it, these cells are dividing and multiplying at an exponential rate, and so it's only going to take a little while before it starts to put pressure on a very small diameter tube, and eventually it's going to make its way through the fallopian tube by a rupture. There can be some blood vessels that are involved in this, and any manner of speaking, these females can be bleeding into their abdominal cavity really quickly. So there can be a massive internal hemorrhage. They're going to have acute abdominal pain. It's generally on one side, and that's because for the most part, eggs are only delivered on one side or the other. Only in a rare case would an egg be released from both ovaries at the same time, which still would be very unlikely that both eggs were actually fertilized and implanted into a fallopian tube. As we were talking about a little bit before, any female of reproductive age, which means Unfortunately, in today's common era, we hear females anywhere from 10 to 11, all the way up to 50, maybe sometimes 55, are now sexually reproductive. Doesn't necessarily mean that they're sexually active, but they are reproductively capable. And so this sometimes can be a very uncomfortable topic to talk to younger females with, but we really want to know about their last menstruation. The last menstruation is a very high indicator of whether or not they may or may not be pregnant, whether they're inside of a certain window of opportunity or not. And if they have not had a menstrual cycle, we want to know if they've ever had one, or if they've just never started, or they've completely stopped their reproductive cycle. And then if they do have a reproductive cycle, we want to know if that pain is associated to something, maybe say polycystic ovarian syndrome, which is a source of significant pain for a lot of females because of the cyst that develops on the ovary when the egg follicle is developing. So this is one of those things where we have to be professionals, and we got to make sure that we're having the conversation with our female patients, because it is very hard to distinguish between a reproductive problem versus another organ problem in the abdomen. Unfortunately, women have a lot more plumbing in their abdomen than the males, and this complicates the matters for us, and we really want to try to be the best historian we can for our patients so we can be their best advocate at the receiving facility. So now we're going to break into the male genitalia and their genital tract. And you guys can murder me on this when I'm trying to say this word, because for whatever the reason is, I am unable to say it with any confidence, and that would be the epididymitis and orchitis. And this is an infection that causes inflammation of the epididymis. And with orchitis, the infection causes one or both testes to become enlarged and tender. Generally, there is a swelling in the groin and to the affected side of the scrotum, and the patient will have a fever because this is inflammation and quite possibly an infection, and the urine will also have a foul odor. Moving forward into priapism, the easy way for me to make this kind of palatable and make most of the students remember this one is that it is an inappropriate erection, and it's not one that's not wanted, but there's no reason for it, or it's inappropriately triggered. So the easy way to think about this is, if you're looking in the results or the causations of it, is a spinal cord injury. When we have a spinal cord injury above the line of the pelvis, the spinal cord injury down, or I should say and down, loses all venous tone. So the entire venous system will lose the signal to stay constricted, and so you'll have mass vasodilation, which will then cause the penis to become engorged. It cannot actually let blood back out of it as quickly as being dumped into it, and so that is a telltale sign for a serious spinal cord injury, is post motor vehicle accident or some kind of traumatic accident that your patient has priapism or this persistent erection. If it's caused from something else like leukemia or a tumor or some kind of perineal trauma or use of certain drugs, these erections can last for several hours, and because of the amount of distension to the tissue, it becomes very painful and tender. It's not something that the male patient is actually looking forward to, and so the big take-home point for this is that you want to maintain some privacy. We want to make sure that we're not making assumptions about what's going on, and have a very clinically correct conversation with the patient, asking if there's any other causes or the like. Moving a little bit more internal, we're going into benign prostate hypertrophy. This is age-related for the most part. It's non-malignant enlargement of the tissue of the prostate gland. And so think of this kind of very similar to cardiac hypertrophy, right, where the thickening of the ventricular walls. On this is older males will develop a thickening of the kind of gland, so to speak, of the prostate, And as this gland becomes enlarged and the overall prostate gland becomes enlarged, it will actually cause difficulty in urination because it's putting pressure on the urethra. And so as you can see, it's saying there's difficulty starting urine flow, and that's because of the increased pressure. And then there's a really slow or a weak urine flow when started. There's incomplete emptying of the bladder because as the bladder empties, it lowers pressure and then it actually lets itself clamp down. And then these patients experience increased urination, right? They're going to get up, try to use the restroom, they're going to lower a little bit of pressure, and then it's going to stop their flow of urine at night, and then so then they'll go back to bed, and then it's going to build right back up because they just let a little bit of this out, and then they're going to let some more out, and it's going to lower the pressure. So it's a vicious cycle for these particular patients. They can also have what's called urinary retention, where they're unable to urinate at all, and this can become an excruciating and actual very serious life threat if not treated. Moving towards the testicular masses, these rarely require any treatment from you. It may be painful, and it may have pain radiating up the spermatic cord, or it could be localized to the specific scrotal point. These patients are going to experience a sensation of like being struck in the scrotum and having a dull, throbbing, aching pelvis. Most of this is basically a benign cystic mass or the like on the testes, and testicular cancer usually presents as a painless solid lump on one of the testicles. The rarely requires pre-hospital treatment is kind of a misnomer there. It's something that, again, as an AEMT, if your patient's in pain and significant discomfort, treat them for their pain. Testicular torsion is a rare phenomenon, but it does happen. It's a twisting of the testicle on the spermatic cord. This generally tends to happen in younger males as opposed to older ones. It's associated with a sudden onset of that scrotal pain that I was just describing, and then they'll have some swelling. It's a medical emergency if the vessels that are associated with that particular testicle have now also twisted, and it's reducing or blocking blood flow to that testis. And so these are people that you want to get to the hospital as well. They're going to be painful, they're going to have swelling, and they're not going to be in a right way. So the torsions can occur with or without blunt trauma. They can have a testicular lump, and you may or may not get some kind of information like there was blood in semen or something like that in regards to your history taking. Moving ever forward, now we're going to talk about aortic aneurysms. And what we want to talk about in an aortic aneurysm, because the aorta obviously comes off the heart, it goes into the aortic arch, and then descends down through the thoracic cavity and the abdominal cavity, branches into the femoral arteries. So a aortic aneurysm is kind of a separation of the linings, right, of the layers of the aorta, and as they separate, blood is able to travel through the inner layers into the outer layers. And there's very rarely any kind of signs or symptoms to this until it's about to tear. So they may have some kind of chest pain if it's a massive aneurysm that hasn't ruptured yet. They may have some kind of throbbing, dull, achy back pain. But if this thing is to let go, more often than not, that patient is ultimately going to end up dying. There's such an immediate loss of blood flow, or I should say of blood, into the abdominal cavity that it only takes a minute or two and that patient is internally exsanguinated or bled out. Speaking of hernias, there's several types of hernia, and the two larger ways to kind of discuss this is an inguinal or a hiatal hernia. You could have a femoral, umbilical, but generally you're going to call it an inguinal if the herniation is at the pubic bone, and it's hiatal if it's anything above the pubic bone along the abdominal wall. And what this is a rupture in a canal that in males is where the spermatic cord and the vessels are traveling through the abdominal cavity into the scrotum. If it's hiatal, it's a kind of rupture through the abdominal muscle or the abdominis rectus. And what will end up happening is small portions of tissue or fluid, and sometimes small portions of bowel will kind of communicate into these holes, or some kind of bulging that may or may not persist. It doesn't actually have to produce something to be there. It can be very infrequent. The general consensus is that most of this is a congenital defect. In the case of an inguinal hernia, this is almost exclusively males because of the way that the scrotum and the testicles have to descend from the abdomen, as they turn into male genitalia. And the hiatal hernias are just a genetic anomaly. It could be a surgical wound that just never really kind of healed up the right way, or a progressive natural weakness in some kind of structure in the abdominal cavity. Reducible hernias, which means that you can see something protruding or some fluid and you can push it back with just a little bit of pressure with your fingertips, are very low risk, and by definition they're able to be pushed back. If we move forward into that, we get into what we would call strangulating hernia. This is a bigger medical emergency. So here's your diagram of different types of herniations and where they would sit in the abdominal area. If you're talking about a strangulation hernia, that means that some tissue that has vasculature or some kind of bowel is now communicating through that rupture in the abdominal cavity or the pelvic floor. It becomes trapped, and as it becomes trapped, it becomes inflamed, it swells, and this kind of chokes off the blood supply, and then that tissue is going to die. That is why this is a serious medical emergency, and they need to see a surgeon as soon as possible. Some of the signs that the hernia has become serious is that a formerly reducible mass is no longer reducible, which means something is trapped. There's pain at the actual site, which is very rare in a typical hernia. There's tenderness when you push against that palpable area of the hernia, and then you see any kind of discoloration in the skin immediately over or surrounding the hernia. So with any abdominal pain issues or acute abdomen, so to speak, you want to make sure that your scene is safe. You're going to take your standard precautions and then consider that this may be a result of violence. Just because somebody says that they have abdominal pain doesn't mean that it's always medical. So keep that in the back of your mind, that this may be some kind of trauma or something like that, or even just violence, both blunt or penetrating. If you have multiple patients that are complaining of GI symptoms, you should have a very high index of suspicion that there is some kind of a release of a biologic or a chemical agent. In reality, this could be something as simple as a group of people got contaminated food or something of the like, but that generally lets them leave the area before it strikes them. If they have an immediate issue, that could be some kind of chemical or gas that's released into the atmosphere, or as some kind of biologic component that's causing this. So you guys want to make sure that if you know that there's several patients in a single location, that you don't become another patient with them. Always, always, always do your primary assessment. You guys are going through your primary assessment. You're going to check for pulses in both arms. You want to make sure that they have equal pulse pressures, that they have equal blood pressures. If you suspect something like an aortic aneurysm, we want to know what their pulse rate and quality is, as well as whether or not they are in like a shocky kind of condition, because that would indicate that we have an unseen bleed. If you see any signs or symptoms of shock, you want to treat for shock and then make sure that they can either maintain or you will maintain their airway for them. Orthostatic vital signs are sometimes helpful in determining what's going on with a bleed. And while I don't do that in an obvious trauma, if somebody is like on the cusp of being hypotensive, I may have them go from a sitting to a standing position to see what their vital signs do. There should be some kind of reaction as somebody changes their position. As the body tries to compensate and keep the brain perfusing, the blood pressure should go up slightly and maybe a small elevation in heart rate. If it goes down or there's not a compensatory mechanism, we should use a lot of caution in that patient. And we want to make sure that we're protecting them. If they were to lose consciousness, do not let them fall and hit the ground, right? We don't want to cause a head injury because we determined that we wanted orthostatic vital signs. As always, you guys know my motto here is that we're not there to cure cancer in somebody's living room. So make sure that we're making a transport decision. The best decision you can make for your patient is getting them in front of the person that's going to do the most benefit for them. We can do a little fluid resuscitation and some comfort measures with perhaps some antiemetics or some pain control, but for the most part, you're unable to cure anything that's abdominal pain related. You can only treat some symptoms. So let's not spend a lot of time trying to pretend that we're going to get something else done, and do what's best in the interest of your patient. Remember your OPQRST. This is how we kind of investigate pain And so we want to make sure that we're using that and kind of try to figure out where that's leading us and what algorithm it is going to get us to it. Does this patient have some kind of infection? Are they febrile? Do they have some kind of bleed because they're hypotensive and tachycardic? Was there trauma involved, or is it specifically medical? What kind of historical interventions with your sample can you get to where today's event makes sense to you? Because as I said before, very few people have a sudden onset of anything. It's generally a collection of symptoms up until a point where they are unable to tolerate it anymore. And at that point, it is now an emergency. When we're performing an abdominal assessment, you always want to explain to your patient what you're about to do. You want to make sure that you expose because you're looking for any kind of distension, rigidity, additional warmth, and you want to see if it's distended. You're going to palpate the abdomen gently. There are other people that will tell you that you should be able to palpate something to where you can perhaps count the vertebrae, but that's really generally a no-no. The idea is not to create additional pain, and we certainly don't want to create any more damage to something that is already damaged. The abdominal cavity is a very soft, tender, delicate structure, and that's why we tend to cover it up and make sure that if we're about to experience trauma, it's protected. Your body instinctively knows that there are several organs in there that are absolutely required for life, and so you'll do most anything you can to protect it. Don't put your patient in any more kind of pain or significant issue than you have to. Remember your compensated versus decompensated shock. Look at the respiratory rate on your patient. Are they breathing rapidly because of pain and they're unwilling to take that deep breath because of the pressure it puts on the abdomen? Are they resultantly hypotensive and tachycardic because they are in shock, or is this specifically a pain response? So if they have a normal heart rate, perhaps a slightly elevated blood pressure, and a slightly elevated respiratory rate, we could say this is a pain stress response. Now, if they're tachycardic and hypotensive and breathing rapidly, we know that this is more of a shock. Make sure that you guys are always reassessing your patient when you think somebody may have some kind of bleed internally, or that they are going to require some kind of surgical suite within the next couple of hours. Any of these patients that you're dealing with should be kind of addressed as a patient that needs to be treated with kid gloves, and you're always going to try to do what you can in the best interest of the patient. Get your baseline set of vital signs, do your assessment, reassess your patient on a regular basis. Don't put large gaps in there. What we're trying to do is show a trend. If your patient is maintaining, that's a good thing. If they're improving, that's a great thing. But if they're decompensating, we want to know that early so that we can change our care plan. If you think that your patient is bleeding or that you're going to need some kind of additional resources, call for an ALS intercept or get a helicopter on the way.